My name is William Lewis, and I'm General Counsel at More Health. And Dr. Shuman was going to moderate this meeting and work with the physicians who've joined, who have generously donated their time, who are generously giving their time tonight to meet with our attendees and to discuss some of the current issues going on with COVID-19, the new coronavirus. And at this point, I think it would be best if each of you were able to introduce yourself. If we could start with Dr. Schoolnik. And would you be able to give an introduction about yourself and your professional background in infectious disease?
Sure. So my name is Gary Schoolnik. I'm a professor of medicine at Stanford University, and I am also an attending physician in internal medicine and in infectious diseases at Stanford Hospital. I also have a research laboratory. I've focused mostly on the study of infectious agents in developing countries, including tuberculosis and cholera and many others. I've had a long association with Fudan University in Shanghai, where I'm on the external advisory board and have been for about a decade. I most recently came off as general medicine attending at Stanford, where I cared for a couple of patients with COVID-19. So my recent experience is, I guess, relevant to this panel. Thank you.
Oh, that's very relevant, and we're happy to have you with us tonight to share your experience. Dr. Lampiris, could you please introduce yourself for the audience?
Sure. I'm Harry Lampiris, and I'm the Chief of Infectious Disease at the San Francisco VA Medical Center and the Associate Program Director of the ID Fellowship at UCSF. I'm also a Professor of Clinical Medicine at UCSF in the Infectious Disease Division. I'm also in charge of the Infection Control Program at our medical center as well, and very involved in the emergency response of San Francisco VA to the COVID-19 outbreak.
Excellent. We're happy to have your experience here and learn what San Francisco is doing to prepare. And Dr. Brewer, can you please introduce yourself?
Sure, I'd be delighted. Hello, my name is Tim Brewer. I'm a professor of medicine and epidemiology here at UCLA. I'm also trained as an infectious disease physician, and I too just came off service where we had a number of critically ill patients with influenza, but fortunately no COVID-19 as yet in Los Angeles, and we're trying very hard to keep it that way. My research focuses on the prevention and control of infections at the population level, and it's included modeling, clinical trials, and a variety of different analytic approaches. And I also, in a previous lifetime, helped to run and oversee something called ProMed Mail, which is probably the world's largest publicly available outbreak reporting system.
Very neat. That's some great expertise, and we look forward to hearing from you as well. I feel very lucky to have such a great group of physicians here with us tonight to teach us more about COVID-19 and their experience and their thoughts on the disease. We thought that it would be helpful to start with a background on COVID-19. And we wanted to learn more about how it started, or what its origin is. And of course, this would be just based on available knowledge at this point, since there's still a lot of unanswered questions. And I was hoping that we could start with Dr. Schoolnik on that question.
Sure, thank you. Happy to give my thoughts on this. The way I understand this epidemic began is that it started with a virus that was circulating in the bat population, and that it's very likely that that virus was passed from a bat to a wild animal, and the candidate for that wild animal is the scaly anteater. And then that scaly anteater, which is actually the most trafficked animal in the world, over 100,000 of those animals are trafficked mainly in China and Vietnam as an exotic food and for medicinal purposes. And that animal probably made it to the wild animal section of the fish market in Wuhan, where the animal was provided for sale, both for its scales, which are part of traditional Chinese medicine, as well as for its meat. And that the virus harbored in that animal, which originated in a bat, then was transferred to workers in that market. And then it had the capacity to be transmitted from human to human. And so the first cluster of cases were individuals associated with that market in Wuhan. So that's my understanding of how this epidemic began. Invite comments from the two other panelists.
This is Harry Lampiris. I just wanted to say that that this is what we call the third zoonotic coronavirus, which means that it's the third coronavirus that we think went from bats to animals to humans. And so the other ones were Middle East respiratory virus and SARS. And so this is kind of also called the second SARS coronavirus or SARS-CoV-2, representing the fact that you can get severe respiratory symptoms with association with this coronavirus. And this is in contrast with other coronaviruses that are much milder in disease and more cause upper airway disease and maybe cause like 30% of the common colds in the world.
So I just noticed, this is Tim, that one of the chat messages had a question regarding one of the statements, and I don't know, Will, if there's a way for us to interact with them in real time. The only thing I would add to what Gary and Harry said is that at least looking at genetic sequences of the virus, this very much looks like a point source outbreak, meaning that it started in one place and then disseminated from there. At least the early data from China suggests that all age groups are susceptible to infection. So there is one preprint that's come out from Zhejiang where they've looked at household contacts, and we thought initially maybe kids did not get this virus, but the rate in children under 10 of infection was similar to all other age groups, but the rate of disease was much lower. And finally, we think that this has been spread primarily by people through international travel. So we do not think that the spread is related to the movement of products or food, for example, which are capable of spreading other pathogens.
Interesting. Thank you. And to answer Dr. Brewer's question, you are able to interact with the attendees' questions in real time if you want. If there's any question that you think is of particular relevance, feel free to either let me know or note it, and we can address it during the Q&A session. We do plan on having sorry if I'm addressing this earlier, but we do plan on having a 10-minute Q&A session at the end of the webinar for people to ask questions. I did have some follow-up questions, but both Dr. Lampiris and Dr. Brewer actually answered those follow-up questions. For the next topic, could you please address how the disease is transmitted? And Dr. Lampiris, could you be the first to weigh in on this question?
Absolutely. So viruses like this are basically usually transmitted by what's called droplet spread, which means the most common way that you get this is that you're within 6 feet of someone that coughs in your vicinity. And it's because these droplets are relatively large, and so they fall around the person that's coughing. And that when people cough within 6 feet of each other, these aerosols land on the other person. And then it's easy for the other person to have that virus be on their hands. And then they can inoculate themselves in their eyes, their face, or their mouth, or their nose. And that's one of the main reasons why washing your hands frequently and not touching your face are two of the major reasons to prevent the transmission of coronavirus. We know that also there may be aerosol spread of this, which is a smaller particle, which tends to, when you cough, stay in the environment for a longer period of time. And the degree to which aerosols cause this is controversial. But we know that from, for example, with flu, it's less likely that flu actually is transmitted by aerosol than by these large droplets. So this question about how much is droplet versus aerosol is a big question for researchers right now. And that most people in hospitals are assuming that it could be either droplet or aerosol, so that they're wearing what's called a respirator to prevent aerosol acquisition of it, the healthcare workers that are around these patients. And that also a surgical mask with an eye cover, which will protect them typically from larger particles that might land in their eyes or on their face. It's also felt that it's possible that it could be spread by stool or bowel movements of patients. And so it's also important to disinfect for family members environmental surfaces, including bathrooms. And as much as possible, it's been recommended that if you're taking care of a coronavirus patient at home, that they hopefully can have their own bathroom, and that if not, that it's frequently disinfected. And I think those are the basics that I wanted to talk about.
I might, this is Dr. Schoolnik, I might add that one of the things we've seen in this outbreak is the rapid spread within closed communities. Certainly in China, there have been very significant outbreaks in hospitals, and large numbers of healthcare workers have been infected, some of them fatally. We've also seen examples of this in the outbreak in cruise ships, particularly the Diamond Princess, where it's a relatively confined population of individuals and where the infection rate has been very high. And then finally, we have seen this again in assisted living facilities and nursing homes, where there's a combination of spread between individuals, as well as the fact that most such individuals in those homes have chronic diseases and or are elderly, and therefore are more at risk for the severe manifestations of the disease.
So just to build on that and to answer one question, so one of the comments that flew by referenced some Singapore data. So there's a study, I think it was in JAMA recently, where they looked at 3 airborne isolation rooms of patients with documented COVID-19 and tried to see could they isolate it off the surfaces and the air vents. And the short answer is yes, you can. And if you clean the room, then you can't isolate the virus. So an important message is the common disinfectants that we seem to use do seem to disrupt this virus. The second is that at least data from China, the attack rate within households is about 14%. So not everybody who's exposed necessarily gets this virus. And much of the transmission, as Dr. Schoolnik alluded to, seems to be in close contact. So the two places where one household contacts and then the second hospitals, as he mentioned. I think the other third point to make regarding transmission is there is very good evidence that asymptomatic or mildly symptomatic individuals can transmit this infection. And in fact, there are now data out of Germany to show that asymptomatic and mildly symptomatic individuals actually have high viremias. And so that is going to be a challenge for us going forward. And that's a distinction from the two other zoonotic coronaviruses that Dr. Lampiris mentioned. In the case of both SARS and MERS, human-to-human transmission was primarily limited to the sickest individuals, and there was not a lot of mildly or asymptomatic transmission. So this virus, even though it is a zoonotic coronavirus, is behaving somewhat different from the two previous ones that we saw when it comes to human-to-human transmission.
So I have a couple follow-up questions. You mentioned that the attack rate within a family is 14%. Can you just clarify for a layperson what attack rate is? I actually don't fully understand what that means.
Sure. So again, just referring back to, it's actually a preprint. I don't think it's been peer reviewed yet, but there's a study out of, I apologize if I get the name wrong, Shenzhen, China, in collaboration with colleagues at Hopkins, where they looked at almost 400 cases and about 1,300 household close contacts. And so basically what they did was contact tracing, and they went out and saw if they could identify virus in close contacts, primarily defined as individuals who either shared a household or a workspace. And my memory, but I could look at the paper again, was that so the attack rate is how many people are infected versus how many people were exposed. So the denominator is the total number of exposed contacts, and infected is her number who tested positive, and I believe it was around 14 to 15%.
Interesting. And are there any conditions that increase the risk of infection? And if we could start with Dr. Brewer on that question.
Probably the things that will increase it, obviously, are the viremic load in the person who's infected. And another difference between this virus and influenza is the infectious period seems to be longer. And the kind of numbers that are being thrown around are the order of 4 to 9 days. Another question that just flashed by was how close is close in terms of close contacts. And I think in general, we would consider close contacts as household members, people who share confined working space, or as Dr. Schoolnik mentioned, individuals in hospitals caring for sick patients. So generally, the longer the amount of time and the closer you're spending with the person, the more likely there is to be transmission.
Thank you. Dr. Schoolnik or Dr. Lampiris, anything to add to that?
Well, I would like to just re-emphasize what has already been said, because I think it's wise and it can be put into action by everybody listening, which is there are certain obvious behaviors that either reduce the probability of being infected, or increase it. So the behavior of carefully, frequently washing one's hands, preferably with soap and water, and washing them for a period of at least 20 seconds, and then refraining from touching one's face, one's eyes, one's nose, one's mouth. That's a behavior that really can be very, very helpful. And that kind of hand care is preferable to using various kinds of germicides, which are alcohol-based or Clorox-based solutions that one can put in one's hand. Obviously, soap and water are not available, for example, in one's car, and one might want to resort to these other solutions. But the most effective intervention that one could do themselves is by hand washing. I think there's some other things that are now being recommended, which is individuals at risk of having severe disease, and those individuals would be persons over the age of 60 and individuals with chronic diseases, for example, diabetes, cardiac disease, renal disease, and chronic pulmonary diseases, that those individuals limit their social contacts by avoiding large crowds and other circumstances where transmission from an infected person to an uninfected person could occur. So that's another behavior that's being recommended. And the basis for that is not necessarily that older people are more likely to be infected, but only that older people are more likely to have very severe disease if they become infected.
And can you help us understand what older means?
Well, older could be seen as data emerging from the various published studies, which look at the risk of severe complications from COVID-19 as a function of age. And we've already mentioned that children probably are as equally infected as adults, but they have mild or no disease. And disease severity then increases if you look at many of the studies coming out of China at ages about 55 and above, and in the United States, just as a cutoff and public health recommendation, that age limit has been set to 60. But of course, the presence or absence of these other diseases are.
So, Will and Marc, if I could just put some numbers on it that may help people. So, based on the joint WHO China report that was published on February 28th, your mortality rate if you were under 50 was under 0.5%, and actually if you were under 20 it was essentially zero. Between 50 and 59, your mortality rate if infected was 1.3%. If you're 60 to 69, it went up to 3.5%. If you were 70 to 79, it went up to 8%. And if you were 80 and above, it was almost 15%. So that gives you a sense of the impact of age on the outcome of this disease.
Might just say that in addition to age, there's also gender. At least in the Chinese studies, men had higher rates of severe disease than women. And it's the explanation for that is not so clear in the United States. While the numbers are still pretty limited, there's more equivalence between men and women in terms of risk of developing severe disease. It may be that in China, where smoking is still common, the smoking rates in men are far higher than in women. And this has contributed to chronic lung disease in many older men. And as well as cardiovascular disease. And both of these may explain why men, at least in China, seem to have more severe disease if infected than women of the same age.
So I'd like to bring up, change the direction for a moment. What kind of protective measures can be implemented for people who are at high risk, or people who think they may have come in contact with someone who's been exposed?
This is Harry Lampiris. Is it okay if I go ahead?
Sure.
Yes.
I just think that we've covered some of these things in some detail already, but one of the important things when to clarify about this particular disease is that unlike the flu, we don't have good specific antiviral preventative measures or vaccines. So like there's no antiviral medications so that prevention is the key. And so the safest way to prevent acquiring this disease is to avoid sick people and avoid people altogether as much as possible in the highest risk patients. So like if you have an elderly, frail mother or grandmother, then you really want to make sure no sick person comes into the house to see that person. And then there are other ways that you can protect, because I think it's the social distancing seems to be a very effective way to prevent the spread of the infection based upon the experience in Wuhan and China. And basically, overall, I think any group activities with a large number of people in a small closed space should be avoided. And a lot of data suggests that that might actually help to reduce the spread as well. And it was already discussed about washing your hands frequently with soap and water for at least 20 seconds several times a day, especially before eating. And using a hand sanitizer that has at least 60% alcohol in it. And then if you're going to touch your eyes, nose, or mouth, to do it with a clean tissue rather than with your fingers. And then do frequent surface cleaning with typical cleaning supplies, and then trying to avoid sharing the bathroom or foods with a sick person. And then lastly, I think that there are certain high-risk locations where transmission tends to occur a lot, and this was mentioned, for example, cruise ships, theoretically large group activities. If you were to have to travel on an airplane, then you can definitely work hard. There's a lot of instructions around on how to disinfect your personal space. And just to remember that if you're in an airplane, you're probably, there's a lot of air recirculation, which is filtered, but that the highest risk probably are the people, are the 1 or 2 to 3 rows in front of you and behind you. And I think that I covered most of it, but I'm happy to hear what the other panelists have to say.
So I guess the only thing I would add is just talking a little bit about the public health response. And the first important message is they actually work, right? So China is now down to under 50 cases a day. They were the epicenter. Taipei, Taiwan, has had less than 50 cases total in a population of 23 million people, and there's obviously a lot of travel between mainland China and Taiwan. And so some of the things that public health agencies can do, which are very helpful, one is surveillance. So you actually go out and test people for it. The second is quarantine. So you have people stay in place. Third is contact tracing. I think this is an area where both Singapore and Taiwan have been very aggressive and probably been extremely successful in limiting the spread within their populations. So that's another thing that you can do as well. And then the last is sort of banning large gatherings, and we're starting to see that happen, at least in the United States. It's already in place in Italy and another number of other countries as well.
What do you consider large?
So I can tell you at UCLA, my university has banned all gatherings over 100 people. My understanding is the cutoff at Stanford is 150. You know, I think we're all making this number up. One of the questions that flew by was, do we have to worry about restaurants? I think the short answer is, in general, the tables are a little farther apart. But if I were in a restaurant near someone who was coughing, I might ask to be moved to a different table.
In Santa Clara County, where I live in California, has banned any performances or other activities where more than 1,000 people gather for either attending a performance or even having banned a outdoor 5-kilometer run has been banned because there were more than 1,000 runners that were signed up. So at least in the U.S., these kinds of restrictions are beginning to apply and being applied at the county and certainly at the state and soon, I think, the federal level.
How effective are the masks, and which are the most effective types of masks? Anyone want to take that on?
So I'm happy to dive in, but I'd love to hear both Harry and Gary's thoughts as well. The short answer is there are no data to show that wearing a mask, if you are healthy and just walking around town, provides you any benefit at all. If you go out and spend the money on an N95 mask for which you have not been fit tested, then you've just wasted more money, right? So you've bought an expensive surgical mask because in the absence of fit testing, you're probably not wearing it appropriately. Where masks are extremely helpful are one, if you are sick and symptomatic, you need to go see a healthcare provider. Call them before you go so they can be prepared for your visit. When you show up, they will probably give you a surgical mask to put on so that when you cough or sneeze, the droplets end up in the mask and don't get disseminated more widely. The other place where masks are incredibly helpful, Dr. Schoolnik and I both just came off service, so every time we were taking care of patients on droplet precautions, we needed to wear masks. And another reason not to just go out and buy masks and walk around the community with them, besides the fact that they don't do anything, is that we then will have shortages for healthcare workers and others who actually need the masks if everybody else is going out and buying them when they don't need them.
So how available are facilities where you can get a fitted mask, given that unfitted masks are unlikely to be effective?
So one comment is that patients that in healthcare settings that we take care of, that we have other diseases that are spread by aerosols, such as chickenpox and measles, all healthcare workers have to be fit tested. It's a requirement by OSHA, so that for the particular type of, it's called a respirator, and there's two major types of respirators that we use in the United States. One is N95 masks, N95 respirators. So I would just call an N95 respirator a high-tech piece of medical equipment that you have to be trained to use correctly, and it's primarily for healthcare workers. And so that basically is for the highest level of respiratory protection. And then the other type is actually, it's called a PAPR, which is a purified air, it's a purifier of air, which is even more effective in reducing, removing aerosol pathogens that are transmitted by aerosol. So The PAPRs we tend to use medically for our very high-risk medical procedures, like when we're intubating patients or putting them on machines or dealing with their respiratory secretions and such. So I want to reiterate that it's simple to remember that the other surgical masks are primarily for sick patients, that the commonly used masks are for sick patients when they're leaving their home, presumably to go to their doctor's appointments and minimal other outdoor activities. And then also for the healthcare workers who need to have this type of protection in addition to the respirators for a kind of extra protection.
So at what point should a patient see a healthcare worker because they're concerned that they might have the virus?
So maybe I can start with that, just the very basics that there's this disease occurs in 3 or 4 separate stages. First, of course, there's the uninfected state, and then there's the infected but asymptomatic state where the virus is replicating in the respiratory tract, but the person has no symptoms or very few symptoms. Then there's the symptomatic phase. And finally, there's the phase of resolution and recovery. So outside of circumstances where populations are screened using very sensitive diagnostic tests, we would not expect, or they have a specific exposure to an infected patient, most such individuals would not be aware that they were ill and therefore would not be tested and would not seek medical attention. The early symptomatic phase is when individuals would recognize they're ill, and in this circumstance of an epidemic, could reasonably seek medical advice. And that initial illness would be characterized by respiratory symptoms and, in most cases, fever, a nasal discharge, sore throat, initially a dry, non-productive cough. And it's at that state where the illness is undifferentiated from other respiratory illnesses, including the common cold, influenza, respiratory syncytial virus infections, or the coronavirus we're talking about today. And that is where I think medical attention and the use of accurate diagnostic tests would be indicated. In the United States, the initial interaction with the healthcare system could be through telemedicine, which is increasingly used, where the patient in their own home can obtain a consultation by a living and visible physician who can give them advice. I think greater use of telemedicine is indicated here to prevent many modestly sick patients from flooding urgent care centers and emergency rooms. If a person is seen by a physician and they are a suspect for a coronavirus infection, then that infection is proven using a sensitive molecular diagnostic test, and the sample type that's generally used is a nasopharyngeal swab sample. And such a test has a sensitivity of probably in excess of 95 or 98%, even early in the illness when the viral load in respiratory secretions is very, very high based on the studies that have been published. I would love to know what the other panelists' comments would be.
This is Dr. Lampiris, and I'll just say that I agree that the things that would make a person seek medical attention the most would be, number one, if you develop symptoms of flu and you're a house call contact of someone, or you know that you've been exposed to a person with laboratory confirmed infection, then you would be the highest risk person that we would want to screen as soon as possible. Or if you had been on a cruise ship, for example, in the last 14 days. But I think it's for most patients, I think that they should think that it's much more likely that they have the flu, because there's a lot of circulating flu right now, than coronavirus. So then you basically should call your doctor and say, you think you have the flu, and do you think you should be evaluated by someone? And that the more high fever that you have, that can cause dehydration, or the more shortness of breath that you have, those are the symptoms that we're really worried about. And I just will make this one distinction between flu and this virus, is that this virus tends to be the more prominent symptoms are fever, cough, and shortness of breath, and it's usually a dry cough. So when people present to their visits, only about 50% of the patients actually have a fever, but then when they're observed in the hospital or in the clinic, 75% of them ultimately develop a fever. So fever, cough, and shortness of breath in medicine, we call it a triad, when you have three symptoms that are common together. And so the triad of this disease is more fever, cough, and shortness of breath. And I'll just say that compared to other respiratory viruses, there's a lot less runny nose and sore throat. So if it's mostly cough, fever, and shortness of breath, it seems to be more characteristic of this disease, and there tends to be less upper respiratory symptoms. And then I totally agree, as much as possible, we're all trying to develop telemedicine systems so that patients can be evaluated by healthcare practitioners without having to go to their doctor's offices and unnecessarily expose other patients to their symptoms. And then they can get specific advice on how to present to healthcare systems and where to present.
Did China employ telemedicine in their response? Does anyone know?
I do not know the answer. I would be very interested to know the status of telemedicine in China.
What's the availability of testing now? And perhaps all three of you can comment at your own institutions.
Well, I will start. Stanford, soon after the publication by a group in Berlin of the reagents or the constituents of the molecular diagnostic test, Stanford adapted that test in the Stanford Virology Lab. And with FDA authorization now, that test is offered as a so-called lab developed test. It has been validated at Stanford and is now routinely used at Stanford with a turnaround time of about 6 hours.
Wow.
Which of course is a long turnaround time for patients who may be waiting in an urgent care center or a emergency room, but it's far better than the test where samples need to be sent either to a state lab or to these in the United States, the Center for Disease Control in Atlanta. There is a compelling need for rapid point-of-care diagnostics for this coronavirus. And of course, complementary to those tests are the existing point-of-care tests for flu A, influenza B, and other common respiratory viruses.
So you would do companion tests?
Yes, I think one way to think about this is because co-infections between this coronavirus and the common circulating respiratory viruses is very, very uncommon based on a number of studies where both such tests have been done. One might first screen with the existing, for somebody presenting with the influenza syndrome, one might first screen with the existing rapid, I'm talking less than 30 minutes, point of care tests for influenza and for respiratory syncytial virus. And if that is positive, then the chance that a person would have coronavirus is low, at least based on current data. On the other hand, if those tests for common respiratory viruses are negative, then I think in the right setting, it would be important to test specifically for this coronavirus. And I believe more and more, at least in the United States, large healthcare institutions will have their own lab developed tests. And I know that the FDA now has emergency use authorization pathways for much more rapid point of care tests, and over 60 companies have actually applied for emergency use authorization for rapid point of care coronavirus molecular testing.
So do you feel you could meet the need now at Stanford for testing?
Well, we can meet the need in terms of throughput, at least so far. I think the throughput at Stanford is 500 tests in a 24-hour period. And I think at the moment, and of course, this is early days in this outbreak, but at the moment that meets the need. It's a very good test, but the turnaround time of 6 hours is long for patients who are modestly ill but not severely ill. So I think we need.
Oh, sorry.
Pardon? I think we need to have tests that are much more rapid, and tests that can be done in more venues than a large healthcare system. For example, in freestanding urgent care facilities, walk-in clinics, and the like.
What's been the experience at UCLA and UCSF in testing?
Should I start? This is Harry Lampiris.
Sure.
So I think that we're all in this situation where it's so rapidly changing, it's kind of mind-boggling. And the general population has been frustrated because people that are not sick and worried well have had the least access to testing. So I would just say that up until this week, we were only allowed to test people that were very sick or had direct contact to a sick person that had known coronavirus. And that up until this week, our healthcare departments had typically maybe 24 to 48 hour turnaround times for those results. And that like Stanford, UCSF is also rapidly developing increased capacity for testing. And we also have a home brew PCR test, which is the same one that the CDC does. Maybe we're a little slower than Stanford because as far as I know, we've only been able to run 40 specimens a day. So I think they're a few days ahead of us. And that the plan is that there's going to be a different assay next week that maybe we'll be able to run over 100 samples a day at Parnassus and China Basin, which are two of the major UCSF sites. And then we think that probably sometime in April, we're going to have some commercially available point of care tests. There are companies that develop these rapid tests for tuberculosis and for other respiratory viruses. And so, but the thing I'd say that is incredibly optimistic to me is the rapidity with which these new assays are being developed. And they're in pre-existing packaging that we already use in our medical centers. So I have to say that even though it's frustrating for the healthy people that are worried, I'm quite amazed by the rapidity with which these new assays are being developed and being used more routinely for healthier people.
And the UCLA?
Yeah, so the only thing I want to add to the excellent summaries from Gary and Harry is, so for our testing, we have an in-house test for inpatients, and we actually have access to Quest Diagnostics has a commercially available test now for outpatients, at least in Los Angeles. The two things I want to add is the rapid point-of-care tests for influenza have terrific specificity. They're not so good on sensitivity. So a negative test on a rapid flu test does not rule out influenza. A negative test on a PCR test does. The sensitivity of the real-time PCRs are much better than the rapid flus. But you can have a negative rapid flu and still have influenza. The second thing I just want to mention is the respiratory pathogen panels have the 4 human known coronaviruses. So doctors have been using that to screen for COVID-19, but they do not cross-react. So do not order a respiratory pathogen panel as a surrogate test for COVID-19. It will not work. So the COVID-19 PCR-based tests do not pick up human coronavirus, and the human coronavirus respiratory pathogen panel tests do not pick up COVID-19.
At what point should a person seek medical attention?
Well, I'll try to start an answer, and so my response would be, it's a combination of the exposure history, the symptoms, and the person's own state of health, including their age. So in this setting, any person who has comorbidities, meaning things like diabetes, heart disease, chronic pulmonary disease, or who may be immunosuppressed for a variety of reasons, or an individual who's over 60. And many people have a combination of all of those things, who in this era develops the kind of clinical syndrome that has been discussed, namely cough, fever, and shortness of breath. That kind of individual should certainly seek medical attention, and they should be specifically evaluated for respiratory viruses in general using molecular diagnostics that have very high sensitivity, as well as for coronavirus. And I think that's a really important message to get across. Individuals with no exposure history, who have very mild illnesses and who are fundamentally well and young, might either use telemedicine, or they might be patient and see how their illness evolves with perhaps rehydration, Tylenol, and bed rest. And only if their symptoms worsen, and in particular they develop progressive shortness of breath or a cough that becomes productive of sputum, then that would trigger, even if they're in a healthy state ordinarily, care and evaluation by a medical provider. I'd be interested in the other panelists' perspective on this.
I think you summarized it excellently, that we think about how sick you are, how many of those symptoms you have, and how short of breath you are, and also how old you are and how many medical conditions that you have. But one thing I'll just want to point out is that if you happen to be taking care of a patient that might have this, and they have flu-like illness, and they have not been able to be tested yet because the testing has not been available, but they might have it, then just to be aware that one of the patterns that's been seen in about 15% of patients to 20% that need to be hospitalized are that they start out with mild symptoms, and then after 4 or 5 days, their shortness of breath gets a lot worse. So if you have an elderly family member at home that you're taking care of, or that you're in touch with by telephone, it's important to do that on a daily basis, because their symptoms may kind of subacutely worsen several days into after when the onset of symptoms occurred. And that's a sign that they may be becoming much more sick.
Do you think it's possible to develop rhythm, both for the lay public and for physicians, in which you can determine the need to get medical attention? I know it would be a work in progress, but I would think it would be particularly helpful given the pandemic nature of this illness.
I think it's a good suggestion, Mark, and I think an algorithm could be developed and illustrated in a way. It would even be possible to have such an algorithm as an app on a cell phone. And
good idea.
I think we know enough now about the spectrum of disease in this illness, you know, in large part from the really excellent medical literature that's been produced in China, with that I think such an algorithm could be very useful, and there are people who are very skillful at doing this kind of thing. I wonder what the Center for Disease Control might think about that. It's something they must have been thinking about, I would think.
Maybe.
I just wanted to bring in at least one question from the audience before we close. This question was asked about 3 times. How contagious are people who are asymptomatic?
Good question.
Well, I can say just a couple of things, and there's no question now that people in the pre-symptomatic period are contagious, and there's no question that people in the asymptomatic period have extraordinarily high viral loads in their respiratory secretions. There's been nice studies by quantitative RT-PCR that's quantified the viral genome in individuals at different stages of the disease, and it's done so in an experimental design where those individuals were contacts of known cases, so they could actually screen them before they got symptomatic, because the risk of becoming infected was sufficiently high to do so. So I think those 2 pieces of information, one is epidemiologic in nature and the other is sort of microbiologic in nature, suggests that that people in the pre-symptomatic period are indeed infectious. I think one thing that's not perhaps appreciated to this point, I don't think it's known, is whether children who have minimal symptoms or maybe pre-symptomatic and how infectious they are, and whether children are an important vector of this disease. So that's, I would say, not yet known. I'd be interested in what the panelists feel about this.
I still think it's early and that the data is still very indirect, and that to really know about infectiousness, usually you have to have an outbreak in a relatively closed population, a fairly large closed population to actually accurately determine the infectiousness. That's kind of a more classic epidemiologic way of looking at it. And I just feel like it's very speculative to know, I agree with you that they seem to be most infectious right before they get sick and at the beginning of their illness. But how infectious they are is really hard because you kind of need a large population being tested to determine that.
And there's one thing, just in agreement with what you just said, is that in the pre-symptomatic state, individuals are not coughing, they're not sneezing, they're not producing these droplet nuclei that are the vehicle of transmission in this disease by and large. So they may have huge amounts of virus, but it's not so clear they're disseminating it into their environment in a very effective manner.
I know there are a lot of other questions, and unfortunately, we're not going to address them. Um, uh, I'd like to thank all of our panelists for an outstanding discussion, and I think it should be really helpful to the audience. And I'd also like to thank Zoom for greatly increasing the capacity to allow people to sign in to hear this educational presentation. Will, do you have anything else you would like to say?
No, I think that you said it. We just really appreciate Dr. Schoolnik, Dr. Brewer, and Dr. Lampiris' time. This has been very informative and very helpful. And just thank you again.
Thank you to everyone.
Thank you for
Thank
having
you.
us, and thank you
Yeah,
to the
I learned a lot from the other panelists, so I want to thank the other two panelists who really taught me a lot during this session too. Thank you.
Bye-bye.
Take care.
Thank you for joining.
Thanks a lot.